back. As I mentioned, we have Dr. Samer Kanan here, who is here on behalf of Providence Mission Hospital. Well, welcome. How are you today?
I'm doing great. Thank you.
Well, thank you for coming in. And you are new to us. We haven't met you before, so tell us a little bit about yourself.
Oh, great. No, I've been here since 2016 at Mission Hospital, and very excited. I'm currently the Director of Lung Cancer at the new Leonard Cancer Institute of Mission Hospital. I'm also the Chair of the Cancer Committee at Mission Hospital, and also the co-chair of the Robotic Surgery Committee at Mission Hospital.
Oh, wow. Well, there's an awful lot going on in there. I know the Leonard Cancer Institute has been there for a few years now. How is everything coming along?
I think it's going wonderfully. I think it's a wonderful collaboration of the donors, the community, the hospital. We have a great team there, and it's really been a wonderful experience for our patients for cancer care in Mission.
Now, for various issues with cancer, is it separated into separate levels, like lung cancer's on one level, or is it cancer on one level and then different things down below?
So in the Cancer Institute, they take care of all cancers.
Okay.
So they have diagnostic areas for imaging, like CAT scans, MRIs. They also have consultations with the medical oncologists as well as with the radiation oncologists. They also have radiation therapy in the basement where they have the state-of-the-art equipment to deliver radiation therapy. So then, of course, they have the physical therapy, nutrition, our nurse navigators, lung cancer, head and neck, breast, GI, all the different lung navigators. We have research, genetics, kind of a full complement of the cancer care. It's all kind of housed in that Cancer Institute, which is wonderful.
Great, that's awesome. And I know that's just right across the street from Mission Hospital there in Mission Viejo. So we're here to talk about lung cancer today, and I know that there's a lot of surprising facts about lung cancer. I think there's things we just don't know about it.
Yeah, no, I think that unfortunately it is the second most common cancer, but what people don't realize is the #1 cancer killer for both men and women. And if you actually take the number of people who die from colon, breast, prostate, and pancreatic cancer combined, that still doesn't equal the number of people who die yearly from lung cancer. So it's far and beyond the #1 killer.
Yeah.
Most people assume and understand that 80 to 90% of people who get lung cancer are smokers or former smokers. So it is preventable as much as we can do to educate, to prevent people from even starting, and then of course helping those that need help getting to quit. We of course have all those resources.
Right, good. You know, let's talk a little bit about those people. I mean, like you said, most people who get lung cancer primarily have smoked or are smokers.
Yes.
Now, is there a period of time, like I know my parents smoked for like 30 years, but what if you only smoke like 10 years? Do you still have that same issue?
So it is related to the number of, we call it pack years. So if you smoke a pack a day for 10 years, that would be 10 pack years. So the more pack years, the higher your chance of developing cancer. Of course, there's a group of patients, 10 to 15%, who are genetic, so they never smoked. They might have just environmental exposures.
Right.
And then the average, it can be up to 20 to 25 years. We call it the latency period. So even though the smoking quit, the damage takes time for the cells to transform and then, of course, convert. So it can be years after you quit.
Okay. Now, among that 1%, you said 10 to 15%, are those folks who have secondhand smoke possibly?
Yes, secondhand smoke is a risk factor. It's not as strong as primary smoking, but yes, secondhand smoke is a known risk factor.
Okay, all right. So let's talk about how it's diagnosed because, oftentimes you don't generally know, like you said, until years later.
Well, there's really two groups of patients. One is the group that presents with symptoms. And unfortunately, when you have symptoms, you tend to be more advanced cancer. So those are people who are having coughing up blood or having hoarseness or severe chest or shortness of breath, chest pain. So we like to catch people when they're asymptomatic and hopefully catch them then when they're early stage so that we can intervene and cure them. And that's where screening comes in, and there's some new exciting things, I think, for lung cancer screening that we want to share with everyone because it is new.
Okay, well, excellent. Well, let's talk about, first of all, the low radiation dose CT.
Of course. Well, there was a large trial And back in 2014-15, the New England Journal of Medicine published this trial, and they found finally that if you do a low-dose CAT scan, that it saves lives, lung cancer screening, and a 20% reduction in the overall mortality, which is very significant. And so the low dose means the amount of radiation is not much more than an X-ray, because it's low dose. And of course, the technology in terms of the way they do the scans, of the body, of the lung. And the idea is that you do a low dose scan, and then you can do it yearly to make sure that there isn't any abnormality. And that saves lives. And we've invested not just with the technology for the low-dose CT scan, but with our lung cancer navigator and our nurses and our team to educate people. So we have all of those capabilities. And furthermore, once patients do have those nodules or those detected cancers, then we have a conference, multidisciplinary, where we review and make recommendations to help those patients.
Okay, and I imagine that in the initial time that they've been checked in with a doctor, that they will have been asked whether you smoke or not.
Absolutely.
Right, and then at that point is when you would decide whether or not they are eligible?
Correct. So the study was approved, and Medicare, of course, approved, and then all the other insurances. Right now, they're looking at age 55 to 77.
Has that changed?
It has changed recently. It's now dropped down to age 50.
Oh, it has. Okay.
Okay. And the pack year smoking used to be 30 pack years, and now that's dropped down to 20.
Oh, I see.
And the idea is they want to catch more patients earlier,
Right.
to try to catch all these cancers and make a difference.
Yeah, absolutely. Now, that's really interesting that they would lower it to 50. Are they finding that they're able to catch it earlier now, or that more people are showing up with earlier stages?
I think it's both.
Okay.
Yeah, and the idea is that, and also instead of 30 pack year, they're trying to get 20 pack year. But we encourage all patients to talk to your doctor, because there are some subsets of patients who are not sure they qualify. Talk to your doctor. You'd be surprised. There are other elements that might be, occupational, if you worked in certain industries, if you have a family history. So you might actually qualify for those purposes as well. So we always encourage, talk to your doctor. The screening guidelines are changing, and we just want to catch patients early, because we know if we catch them early, we have a chance for cure.
Excellent, excellent. Now, off camera, we talked a little bit about you having robotic experience, and you're in charge of that. And so tell me a little bit about, that's one of the treatments that you can use for lung cancer, correct?
Absolutely, right. Typically, there's surgery, chemotherapy, radiation, and all three of those have really revolutionized in the last few years. But robotic surgery is a minimally invasive approach, and currently with lung cancer, if you can remove it surgically, it offers the best long-term cure.
Okay.
So we push for that, and patients can have small 8mm incisions, go home in 1 or 2 days, compared to the large incision in a week or two in the hospital. So it's really revolutionized how we care for them.
Right. Now, also, let's talk about video-assisted thoracoscopic surgery.
Yes. So robotic surgery is very similar to VATS, or video-assisted thoracoscopic surgery.
Okay.
Both minimally invasive.
Okay.
The advantage, the reason I moved from doing VATS to robotic is, and it takes time to train and do that, the robotic is three-dimensional, and the instruments kind of have full articulation with your wrists, versus the VATS are more fixed and two-dimensional. But both are minimally invasive, and both are preferred than the open approach, which can certainly have a lot of pain and recovery. And we, of course, offer those at Mission Hospital, and very excited, because I think it really does make a difference in the patient's recovery.
At what point would you decide to use one or the other?
Well, I think it depends on, of course, your surgeon. Myself, I started with open in my training. I moved to VATS early in my career, and now I do exclusively robotic surgery. Okay. I just find it to be superior, and but I encourage patients to connect and make sure you have a good connection with your surgeon. But I do feel that robotic surgery is kind of the future, and you'll see more and more of that for not just lung cancer, but for all the colon, prostate, uterus, all those surgeries we're doing robotically now.
Seems like all surgeries are heading in that direction for sure.
They are. It's very exciting.
That's great. Well, thank you so much for the information. We
Oh,
appreciate it.
wonderful. Thank you.
And we'll be right back after this.